Okay, I think we'll go ahead and get started, everybody. So it's my great pleasure and honor to introduce Professor Hoon Shin, who's here visiting us from Korea this week. We've had a wonderful week sharing cases in the lab, had wonderful lectures on thoracic duct leaks and on gastrostomy access, and looking forward to today's presentation. He is a good friend of our division and department. We've had a visiting professorship, a sabbatical position that Dr. Shin was our first international professor to do that back in 2009. And thanks to his efforts, we've had the good pleasure of having several of his Korean colleagues come also spend a year with us. And it's been a wonderful, enriching opportunity for us to have these very senior, experienced IRs come from Korea and spend a year with us doing their research, but also just sharing ideas with them in the Angio Suite. He works at ASAN Medical Center, and I thought I'd spend a moment just talking about where he works. It's the most respected hospital in Korea, recognized internationally as one of the top hospitals in the world. They are leaders in cancer, heart disease, and transplant. They have 2,765 beds. They see 11,000 outpatients a day, and that's 1,822 physicians and 9,500 employees. Just to put that in comparison, we have 1,000 physicians and 16,000 employees for our 679 beds and 3,500 visits. So they work really hard. So they deserve the sabbatical. So we're glad they choose to come spend it with us, but it's definitely a year they need to recover because their days are long. And for IR comparison, those that work in IR, they have 7 rooms like we do, and they do 100 cases a day compared to our roughly 30. So it's very impressive what goes on there. He graduated from Hanyang University with an MD in '94. Did his radiology at Osan University, finishing in 2001. Actually practiced for 1 year as a neuroradiologist before Dr. Sung, who's a very famous IR and translational research expert in Seoul, recruited him to come be an interventional radiologist. He got his PhD from Soonchungyang University in 2004 and has been faculty at ASAN ever since 2002. I got his associate's degree in 2010, full professor in 2016. He's been visiting professor at many places, but has spent time in China with a long-running relationship with their professors in interventional radiology there. He's been associate editor for KJR, associate editor for International Journal of GI Interventions, and now chief editor for the Korean Dialysis Journal since 2022. Most recently, he's been the president of the Korean Society of Interventional Radiology. He'll be finishing his tenure in this year, and that's a highly distinguished position there as well. He has been PI for over 28 translational and clinical research studies. He has 3 patents. He's supervised over 10 master's and doctorate degree candidates, and of course, numerous radiology residents. He's written 12 book chapters, over 400 peer-reviewed articles, and in my looking at them, he was first or second author on almost every single one of them, which is just unheard of. I was so impressed to see that. Has done well over 150 invited presentations. So with that, I'll turn it over to Dr. Shin. Thank you so much for being here with us today. We look forward to your presentation.
Thank you. Thanks, please. Okay, I'm talking about sclerotherapy for ovarian endometrioma. Before starting the scientific thing, as you told, spent 1 year and it's very my honor to have Alan and Fritz here. This was taken before 2009, before I came here. And these are lecture titles found in my surviving files. So I think around 10 lectures for 1 year I'm here to the residents and fellows here. This is summer slide after coming back to Korea. This is my impression at the time. It was very active in aortic and peripheral artery disease. About 4 stenographs per week, and cooperation was good. And then Dr. Lake, Dr. Matsumoto, and Dr. Anger were mentioned. This is the work I done with these faculties, and then Alan was the corresponding. It was a really an honor to have written paper with material here about penetrating aortic ulcers. Published 1 year later after I came back in CVIR. Thanks so much. And it was also my great pleasure to invite Fritz to ASAN Medical Center. It was a timetable at that time. It was already almost 10 years before he gave lecture. It was about 5 lectures, much more than me. Thank you. And yeah, he was very passionate. To my residents and fellows in NJVP room with the neuroradiology team, and also my research team. Jeep comes to Korea very often. He went 2024. Okay. Thanks, Jeep and Dina. Monica visit last year. Okay, I heard she'll join in 2 months. And then last year there was a really good news. I recommended Alan to be an honorary member of KCR, and it was approved last September. And then I gave him WeChat or WhatsApp. Okay. And so it is an honor to have him in Korea this September. He will come as an honorary member of KCR. And after my coming back to Korea, connections continue. And then I wrote down a chapter about enteric access in IR playbook. Thanks for Jeep, Fritz, and Alan. And also, I wrote down the chapter about airway intervention in image-guided interventions by proposal from Alan. Thanks. And Ami Taylor, Ami, and Olivia came to Korea this year, and also to my hospital. And Dr. Taylor gave a lecture to us. Thanks. And then this time, went to Fritz mom's home with Korean doctors. Yeah, and then last night in Tabolo, it was we had a good time. It is a small hut in Korea style. Okay, thank you. Yeah, compared to surgery, which is standard therapy, but with significant reduction of ovarian reserve, anti-Mullerian hormone decline, and because of removing healthy ovarian tissue and thermal damage. But catheter-directed sclerotherapy is ovarian sparing alternative and minimally invasive, no scars, and less than 3 days. Usually 2 days, 2 nights, necessary for this therapy. About 40 years ago, neither sclerotherapy was done by a gynecologist. They put the needle and aspirate as much as possible, and then inject alcohol. They used 16 to 19 gauge needle, but recurrence rate was high. This is from our meta-analysis published in European Radiology. as high as 60, more than 60% in certain reports. It's because with a needle, very difficult or impossible in many cases, aspirate the whole inner contents because it is very thick usually. Compared with 18 gauge needle, 7 French, 8.5 French, you can see this is real ratio. So compared with needle, the catheter has a bigger lumen area. So when calculated, at least 4 or 12-fold bigger in area compared with needle when you use 7 or 8.5 French catheter. It means we can aspirate the inner contents completely. This is a concept of catheter-directed sclerotherapy. It is from my colleague in Severance Hospital in Korea and published in Radiology 2018. It is the first report on CDS, catheter-directed sclerotherapy, based on 14 patients. They show diameter and volume reduced significantly, and then but anti-mural hormone was not different. So it's to overcome drawbacks of needle-directed sclerotherapy, we put the catheter under ultrasound guidance, and then aspirate contents, and then contrast study to rule out leakage. Then alcohol or injection and indwell for 20 minutes with position change if possible, and then aspiration of alcohol. That's all. So we need this kind of adapter. It's from your country, things. Via this adapter, we insert the needle under ultrasound guidance. We use 18 gauge needle, and then remove the inner stylet and insert the catheter. And then over the catheter, we insert the over the wire, and we insert the catheter. So puncture on the ultrasound and fluoroscope guidance, and insert the needle as much as possible, and then remove the ultrasound probe. Then over the wire, insert the catheter, and then aspirate. So that's why we call chocolate cyst based on this contents color. So in summary, puncture and then aspiration, and it is not enough with only aspiration. We inject saline and then irrigate fully to empty the cavity, and then capillography with contrast media, and then remove the contrast agent and then alcohol for 20 minutes. And I do is routine to have second session with the same amount of alcohol for maximum efficacy. In Korea, another 2 institutions do this CDS actively. In other 2 hospitals, they do only 1 session, but I do a second session. So second session is easy because the catheter is kept, and then just do sclerotherapy and remove the catheter at the end. Alcohol volume, usually 50% of the aspirated volume, and maximum dose in my personal practice up to 200 milliliter, but exceeds 200 milliliter is without problem, I believe. And usually for hepatic or renal cyst sclerotherapy, they say 100 milliliter is maximum, but I believe ovary is more tolerable to alcohol. And then we sometimes need more volume as we inject 50% of the aspirate volume, and sometimes big cyst. The volume is, for example, 150 or 200 or even larger. We sometimes use disposable or needle guide. It's also from the same company in Michigan. We use 99.5% alcohol or from Taiwan. This mechanism is, here. And puncture under ultrasound guidance, you can see here this guide indicate here, and puncture, and then see the tip of the catheter here on the ultrasound. And on the fluoroscopy, insert the guide wire and insert the catheter and remove, and then sometimes saline injection and also removal, irrigation, and contrast injection to see there is leakage or not. So it's a movie. So yeah, you can see a puncture. Transparency access and remove the stylet and insert the guide wire. It is 0.035 inch soft thermal guide wire, and sufficient amount of guide wires inside the cavity. Remove the probe and needle, and then only guide wire is left. Then insert the catheter. Before inserting catheter, recently I insert the inner style, only inner style first as a pre-dilation, then the catheter insertion followed. It's better to insert the catheter like this, and then aspiration as much as possible, and then contrast injection shows to see the leakage or not, and then remove the contrast, and then alcohol or irrigation, for example, 5 to 10 cc, then real alcohol sclerotherapy. 240 cc was removed. This patient, about 6 centimeter, right ovarian endometrioma. After a procedure, 2 sessions sclerotherapy, 1 month, 3 months, 6 months shows diameter decreased, volume decreased, so volume reduction ratio more than 99% in this patient, and AMH a little bit decreased, but hospital gynecologist usually prescribe the hormone drug. So they say a hormone drug can affect antimural hormone reduction. So actually, it's not affected by sclerotherapy much. This patient in 20s and also the before, and 1 month, 3 months, 1.5 year actually has gone. This patient has 2 endometrioma in right side and left side single. In that multiple, we can do multiple catheter insertion at the same sitting. The largest one in the right side and the left side, and then the right side smaller one. So total 3 in a single session we do. And then 3 months follow-up shows you can see volume reduction ratio for each cyst more than 96%. This patient has 3 endometriomas in the only left side. So 1, 2, 3. So in the case we insert the 3 catheter into the left side and found out communication between the first and third one, and second one not communication. Anyway, also more than 90% on 3 months follow-up, volume reduction ratio was achieved. Pain is observed in most patients, but very subjective, very minimal to very severe. It's alcohol related. So we prescribed the patient, we gave her antibiotics. Nowadays, Maxigesic. Previously, we did fentanyl. Anyway, antibiotics is necessary, and contrast leakage is sometimes seen. It was known as a contraindication of alcohol or sclerotherapy, but I found out that reduced dose alcohol is usually okay. It is not severe. And catheter clogging are very rare, but in case we can change a larger diameter at the second session. Pelvic abscess, I don't experience at all. And vaginal bleeding, most temporary. Okay, this patient, 3.4 centimeter, and first time is 20 cc aspirated, no leakage, and about half of alcohol for 20 minutes, painful anyway. But second session, I found that the leakage. So this is not small. So second session, alcohol sclerotherapy not done. So only first session, one session was done. But 1 month, 6 months, and 2-year follow-up, the result was good. So we do 2 sessions. So if there is a leakage, at least one can be successful. I think it is also good. This patient, 5 centimeter, 35 cc aspirated. And you can see here at the first session, leakage. But I did about 20% of volume, there is 7 cc alcohol, so reduced volume as usual, were administered and indwelled and for 20 minutes. But second session, there was no leakage. So this patient also showed 1 session leakage, but another session is okay. And this time, 10 cc sclerotherapy was done. And then follow-up shows 5 centimeter to 7 millimeter. They're quite successful. And higher chance of at least 1 successful procedure as we do 2 sessions. And AMH decreased a lot in this patient. So I'm not sure, but possibly decrease AMH more when alcohol extravasation is possible. And transabdominal access we sometimes do in this patient. Transvaginal, we have transgressed the uterus, but in transabdominal, it seems easier. So transabdominal access was done as we do usual PCD. And then you can see here, puncture, we use now chiba needle and hair guide wire, and insert the thermal or guide wire, and then insert the catheter, and there is no leakage. And then the second session is good, and then remove the catheter on the fluoroscopy. And then you can see here, 6-month follow-up shows marked decrease of diameter. This patient, you can see right and two twin-like cyst. So we don't know it is communicated or not. Anyway, the larger one was punctured and insert this time it is large. So we insert the 10.2 French multicidal Cook product is alcohol resistant, so no problem when you use Cook product. And 420 cc aspirated, and found out there is a communication with smaller one. So with 1 catheter, we can treat both as there was communication. And second session also we found that communication also. And before and 4 months later, it was decreased a lot with resolution of abdominal pain. So we can use single catheter for communicating cysts. This patient has multiple or 4, it seems separate, and done through transabdominal access in a single session 4 catheter like this. And this amounts of aspirated contents, and can use multiple catheter in single session, up to 4 in my experience. So it was published 2024 or 2-session CDS using ethanol in 22 patients. So it is our data, more than 96% volume reduction ratio, and anti-mullerian hormone was a little bit decreased, but not significantly different. Gynecologist's opinion say it is usually from the Lausanne like hormone drug. And then when compared with needle-directed catheter-directed sclerotherapy, aspiration is easier, and you can guide both ultrasound and fluoroscopy guidance. We can do capnography, and we can reuse the catheter, but for needle, for repeat procedure, redo puncture. And so the first needle-based sclerotherapy is done by gynecologists in local as an outpatient base. In our hospital, this work is still done on the inpatient base. But I think it can be converted to outpatient in future. And it is better for large cyst or high viscosity contents, and need for thorough irrigation and prolonged ethanol contact, and greater post-treatment cyst size reduction is expected. This patient is small, 3 centimeter, and better feasible for transabdominal, but it was failed. It is very small size, so leakages, so it was failed. So high failure rate for small size, less than 3 centimeter. This patient, twin-like endometrioma, and looked like there was communication on ultrasound. The larger one was punctured and inserted the catheter, and found out the communication with another smaller one. And then second session, I tried to insert the catheter guide wire into smaller one, and then insert the multisidal catheter to drain both more effectively, like this. So catheter extension is possible to another chamber if communication is there. This patient left 7 centimeter, you can see here. As I told, you can see here, before advancing the catheter, insert only inner wire for pre-dilation. It's much, much helpful to advance the catheter. Only the catheter, as usual, advancement, sometimes there is resistance, but after pre-dilation with inner metal stylet, it is easier, I'm sure. So use of inner metal stylet to facilitate catheter advancement. And 8.5, sometimes 10.2, friends, this kind of multisidal BSL type of Cook and catheter. And in this patient, I did multiple times of irrigation, but still found out some filling defects. I think it is very old blood clot. It takes around 20 minutes, but cannot aspirate all sometimes. And in this patient, in 6 hours later, I did. I started second session. The catheter is kept and aspirate the inner content first, but it doesn't work. So I thought it is clogged. So I changed it with a bigger one of the guide wire with 10.2 catheter, and then removed 8.5 catheter. You can see here clogging, and then you can see blood clot. So we can use the large sidal or bigger catheter. This patient CAT scan insertion as usual, but you can see here a little bit strange thing here. Yeah, what is this? This is there was no contradictory. It was made by me with scissor. I made a existing side wall bigger and then and made a new bigger side wall for better aspiration. Sometimes I do like this. Making side walls larger. I think it will be helpful. This is a report by another Korean group comparing surgery and sclerotherapy. It's a retrospective study in European radiology, and hospitalization days were much shorter than surgery, and complication and recurrence were also better in CDS, and serum AMH is preserved in sclerotherapy, but decreased a lot in surgery. In several hospitals here, they usually don't prescribe the hormone or Lausanne like something. It's policy of gynecologist. So in summary of catheter-based sclerotherapy, I make the rule to have 2 sessions. We need these kind of things. Endocapillary needle guide is really necessary. Just freehand puncture is not easy and not recommended. And in other hospital, they do 7 French, but I nowadays usually use 8.5 French or sometimes 10.2 French, especially if the cyst is large. And lidocaine irrigation and alcohol irrigation, 5 to 10 cc, and then alcohol sclerotherapy with about half volume of the aspirated contents for 20 minutes, and multiple catheter insertion sometimes, and transabdominal sometimes done. So I meet the patient before the procedure for interview and ultrasound by myself, and AMH checkup and procedure. And after the procedure, I meet 3 times, 3 and 6 months and 1 year is most suitable. Actually, nowadays, recently, so far, all patients are referred from gynecologists. They refer when there is a low ovarian reserve and recurrent region after operation, because operation is a big burden in this situation. And I think diameter more than 3 centimeters is usually feasible. However, naive patient with normal ovarian reserve or without operation history seems also indicating. These analyzed factors affecting the technical outcome of CDS, and then they say small size. I agree with this. And in the hospital, MR imaging is routinely done, and they found a T2 dark signal intensity, which indicates chronic stage blood clotting. It means very thick. It means we need vigorous irrigation. So they realized it is with poor outcome, but I don't agree with this. I can irrigate sometimes 20 minutes, 30 minutes to irrigate almost all contents remove. So I believe if we can remove the inner contents, this is not risk factor. They say transvaginal access, but they are different from mine. They, in their procedure, only 30% is done by transvaginal, 70% transabdominal. But in my case, more than 90% transvaginal. Transvaginal I prefer because it is more stable, and I think there was selection bias because they small size. When transabdominal access difficult, they did transvaginal. So they found this is also a risk factor, but I also don't agree with this. Anyway, we need more evidence. MR imaging is helpful or confirm diagnosis and characterize reason, and we can see these things, but it depends on the hospital. Now I'm going to show you one very short cases, two cases actually. It works also for other pelvic cysts. Usually they are serious and like this pathology. This patient actually is not gynecological problem. She underwent surgery for Crohn's disease, but abdominal pain and distension. You can see big mass in the lower abdomen and pelvis. Is peritoneal inclusion cyst related to Crohn's disease and operative history. So long diameter, 18 centimeter, transabdominal approach done, and insert the multisidal, and then aspirate more than 1 liter. This kind of water is not thick at all. And see this with 100 cc at a time. And second session, same 100 cc alcohol. And 4 months follow-up shows you can see dramatic decrease. 22 months follow-up, there's no peritoneal inclusion at all. It was, and the abdominal pain severe, but it was resolved. And then AMH was not affected because it is not actually the ovary related. This patient, cystic history 14 years ago, like this big cyst, similar method, but transvaginally in this patient, it is very some stroke color, not chocolate cyst with this sclerotherapy, 2 sessions, and 2-week follow-up shows you can see reduced diameter, and still, the follow-up you can see it disappeared. 3 months follow-up shows completely disappeared. So this outcome for symptomatic peritoneal inclusion cyst were recently reported in Korean Journal of Interventional Radiology. And I got this handwritten note from the patient. It is very touching. In our hospital, or the surgery potentially lead to infertility, and she was assured by my comfort, and then she became very good after this procedure. So it's very rewarding to me. Take-home message is very safe and effective, and shows superior ovary function preservation. And I think 2-session protocol is good for maximum efficacy. And there are some technical tips, many of them are from my personal experience. Okay, this overview was briefly summarized in this KJIR. You can scan this and then find out this short mini review. In this review, there is a recording, very well made recording, a movie you can refer. Thanks for your attention. Is it comments or question? Okay.
Endometriomas, is there any theoretical risk or documented risk of tracking any or seeding any endometriomas along the tract, either percutaneous or vaginal?
Oh, no. Maybe it is orthodox, so I don't. I've never seen such complication. Okay.
Thank you for that extraordinary experience. I've been doing this here for about 2.5 to 3 years, but all cases have been transabdominal. I've never done any transvaginal, so that's very interesting. Thank you. And I've never put that much alcohol in the patient. I've only seen some of the complications. But you said you've been placed with 200 cc's for 20 minutes. And you haven't had any alcohol toxicity or intoxication, or what? is I'll usually stop at 50 or 60 at the most, CCs, and then I'll let it sit for 1 to 2 hours. If you've got a very accelerated, fast use with a large amount, tell us more.
Oh, yeah. You use small amount, but you do for 1 hour?
1 to 2 hours.
Or slow?
Then I empty and I take out the catheter, but
I know.
a smaller amount.
Right. And you aspirate the contents, yeah? Before injecting the airport line.
Yes, absolutely. But
Yeah.
you have not seen any intoxication with volumes?
Yeah, sure. Actually, in my personal experience, the maximum amount of about 180, and then I found out actually no real intoxication. I ask every time, how's your feeling? But yeah, do you feel you drink alcohol? Most people no, but some people a little bit, but very much. So I think it is not much systematically observed. Of course, there will be, but a very small amount. So I think that's really no problem.
And when you do your 2 sessions, you keep them there all day?
Ah,
They
previously,
for 6 hours with just the catheter?
yeah, sure. For example, today afternoon I did, and then I had the next patient, next session, the next morning. And then,
They go home with.
yeah, next morning, second session, next morning as a first case, 8:30, from 8:30 a.m. And then sclerotherapy, then remove the catheter and discharge. Yeah, right. But sometimes we do 2 sessions in a single day, with the early morning and late afternoon. Single.
So if you start the first session in the afternoon, the patient is admitted to the
Yeah,
hospital?
sure.
Okay.
Keep the catheter and overnight.
Okay.
In the hospital?
Sure, in a hospital.
Just stay.
Yeah, sure. Admission. And then I know you are very take care of the patient pain or sedation. Some alcohol is some painful, but I think it is also necessary to evaluate the pain because it is too severe. It can be some alcohol extravasation, and then it needs to stop the procedure and aspirate the volume, aspirate the alcohol. So sedation is not an answer, I think. Or we can pain control. We can do pain control. If it is too severe, I think it's better to stop the procedure. Yeah. So with sedation, I'm worried about they cannot express their pain. Yeah.
Shin, thank you so much for very, very excellent presentation and cases. Images, of course, are amazing. Thank you.
Thank you very much.
We have a small thank you we want to give you from all of us for being our speaker today. So thank you very much. And, yeah, so don't worry, we'll mail it to you. You're trying to take this on the plane.
Yeah, I can be.
If you wish. Anyone that hasn't had lunch and has got the issue, 2M conference room lunch.